This is part 2 of a 3-part series on the interpretation of the urinalysis, and I'll be focusing on the dipstick. The learning objectives here are to be able to explain how the dipstick is checked, and to explain the significance of individual abnormal findings. A urine dipstick consists of a series of pads embedded on a reagent strip that provides a quick, semi-quantitative assessment of various potential contents of urine. The specific contents tested may vary very slightly between different manufacturers. How does a dipstick actually work? Well, it's amazingly simple. Just take the reagent strip and either dip it directly into the urine, or alternatively, use a disposable pipette to thoroughly soak the strip. Wipe off the excess fluid, and then wait a predetermined length of time, which is usually about 30 seconds, but may vary depending upon the manufacturer. At this point, compare the colors of the individual pads against the standards that are provided. So for example, focusing on the bottom pad, which corresponds to glucose, we are trying to match the tan color on the strip with one of the colors in the bottom row on the standards. And it seems to match the second to last one pretty well, which corresponds qualitatively to 3+ out of a possible 4+ scale. We then repeat this process for each pad, moving up the strip. The chemical reactions occurring in the pad require different lengths of time. With this manufacturer, glucose takes the least amount of time to read at 30 seconds, while a read of leukocyte esterase must wait for 2 minutes to first elapse. Conveniently, the order of pads is placed on the strip in order of increasing reaction duration. I'm now going to run through all of the individual tests on the strip. First up is specific gravity. The specific gravity is a measure of relative density. In this case, the ratio of the density of urine to the density of water. Although urine is mostly composed of water, because it also contains electrolytes and urea, among a few other compounds, it's always slightly more dense. In the absence of highly unusual circumstances, the specific gravity can vary from 1.001 up to about 1.035, depending upon renal perfusion and volume status. There's an interesting, very general, yet still useful rule that urine osmolality in units of milliosmoles per kilogram is approximately equal to the specific gravity minus 1 times 35. This is helpful when assessing for things such as primary polydipsia or diabetes insipidus, because a urine osmolality can take many hours to be run by the lab. However, this equation is inaccurate in the setting of significant protein or glucose in the urine, since those conditions will increase the density out of proportion to the osmolality. What types of conditions lead to alterations in the specific gravity? Well, under normal circumstances, that is when the body is euvolemic, renal perfusion is normal, and the kidneys are healthy, the specific gravity tends to be right around or very slightly below 1.010, which implies that the urine osmolality is very roughly the same as that in the serum. If the specific gravity is close to 1.001, that is, urine is more dilute than normal, it implies the patient has excessive hydration, a condition called diabetes insipidus, which can be caused by either deficiency or resistance to antidiuretic hormone, or ATN, in which the kidneys lose the ability to concentrate urine in the tubules. A specific gravity close to 1.035 largely implies the opposite, that is either dehydration or SIADH, that is the syndrome of inappropriate secretion of antidiuretic hormone. It can also be seen in the impaired perfusion that's seen in CHF and cirrhosis. And finally, as mentioned a moment ago, glycosuria, that is glucose in the urine, proteinuria, and recent administration of IV contrast, which has a relatively high molecular weight, they all lead to high specific gravity as well. Occasionally, you might encounter a patient who has a specific gravity that seems fixed right around 1.010. No matter whether the patient is dehydrated or overhydrated, the specific gravity doesn't seem to vary very much. This person likely has advanced kidney failure, in which the kidneys lose their ability to regulate urine concentration. Moving on to pH, depending upon the physiologic state, The kidneys can produce urine with a pH ranging from 4.5 to 8.0, though the lower limit of detection on some dipsticks is 5.0. When the kidneys are functioning normally, they will excrete more hydrogen ions in acidemia, resulting in lower urine pH, and excrete less hydrogen ions in alkalemia, resulting in higher urine pH. There are situations in which checking the urine pH is particularly helpful. First, diagnosing a renal tubular acidosis. Second, monitoring urine alkalization in order to prevent precipitation of myoglobin in rhabdo and to aid in the elimination of certain drugs, such as aspirin and methotrexate. The urine pH is also helpful in differentiating different types of kidney stones, since different stone types develop under different acid-base conditions. Causes of extremes of pH are relatively straightforward. pH that is close to the lower limit of physiologic possibility, that is, around 5 or lower, is usually due to acidemia, either from hypoventilation or from excessive production of lactate or ketones. A pH between 7 and 8 can be the result of alkalemia. A higher than expected urine pH can also be seen in some RTAs, as well as in UTIs from organisms that produce urease, which catalyzes the breakdown of urea into ammonia. One very strong point of caution, however, the urine pH is highly dependent upon diet, and therefore one should not use it to infer anything at all about the acid-base status of a patient in the absence of an ABG and metabolic panel. So, for example, having a urine pH of 5 absolutely does not mean that a patient's serum pH is necessarily abnormal, or that there is anything at all pathologic going on. The urine pH can only be interpreted within the context of other labs. Glucose. It's freely filtered through the glomerulus, but almost all of it is reabsorbed in the proximal tubule. As already mentioned, glucose in the urine is referred to as glycosuria. If severe, glycosuria can lead to an osmotic diuresis and subsequent dehydration. There are very few causes of having detectable glucose in the urine. First, and most obviously, is serum hyperglycemia. If too much glucose gets filtered, it can overwhelm the tubule's ability to reabsorb it. Much less common is proximal tubule dysfunction. Global dysfunction of the proximal tubule is called Fanconi syndrome, which also leads to hypophosphatemia and a proximal renal tubular acidosis, among other things. Glycosuria can also be from a genetic defect in renal glucose transport within the tubule. Next up, heme, also known as blood. The urine dipstick for heme is highly sensitive for hemoglobin. However, it also detects myoglobin. Thus, detectable heme can be either from any cause of hematuria, or bleeding in the urinary tract, or from rhabdomyolysis, which is acute muscle breakdown. I've also heard and read that contamination with semen can cause a false positive result. The detection of protein on urine dipstick is most sensitive for albumin and relatively insensitive for immunoglobulin light chains and other non-albumin proteins. In addition, the sensitivity is highly dependent upon urine concentration. In other words, the more concentrated the urine, the more sensitive the test. As with several components on dipstick, proteinuria on a UA is reported on a 1 to 4 scale. However, published charts that attempt to correlate the 1 to 4 scale with a quantitative protein concentration should be used cautiously, since the correlation is not great. Etiologies of detectable protein include any form of glomerular disease, such as diabetic nephropathy, as well as overflow proteinuria from things like multiple myeloma, rhabdomyolysis, and intravascular hemolysis. Remember that since the dipstick is not sensitive for non-albumin proteins, it is therefore going to have very low sensitivity for any of those conditions. Finally, patients can have what is sometimes referred to as post-renal proteinuria, in which the high protein content occurs somewhere downstream in the GU tract, for example, due to a UTI. The last really important constituents of the dipstick are leukocyte esterase and nitrites, which should really be considered together. These are often used to aid in the diagnosis of UTIs. Leukocyte esterase is an enzyme released by white blood cells, also known as leukocytes, and is used as a qualitative measure of white blood cells in the urinary tract. Direct-to-consumer dipstick tests frequently refer to the leukocyte esterase test as simply, quote, leukocytes, but the dipstick isn't directly measuring white blood cell concentration, just enzyme activity. Nitrites specifically detect the presence of bacteria from the Enterobacteriaceae family, which convert the normally present nitrates in urine into nitrites. Notably, Enterococcus species lack the ability to form nitrites. There are a few other reasons for a negative nitrite test, despite the presence of bladder bacteria. That includes insufficient bladder incubation time, decreased excretion of nitrates in the urine, and a low urine pH. When comparing leukocyte esterase to nitrites for diagnostic utility, keep in mind that the former is only a marker of inflammation, while the latter is more specific for actual bacteria. So, for example, both can be seen with UTIs and with indwelling urinary catheters, even in the absence of pathologic infection. However, only leukocyte esterase is typically seen post-instrumentation of the GU tract, in urologic malignancies, chronic interstitial nephritis, interstitial cystitis, and in an intra-abdominal inflammatory process that happens to be adjacent to the GU tract. This diagram does not hold up 100% of the time, but it's a good general guide. Now we move on to a few remaining tests on the dipstick that are less diagnostically helpful and which some hospital labs don't even routinely report. First among these are ketones, more specifically ketone bodies. To remind you, there are three ketone bodies: beta-hydroxybutyrate, acetoacetate, and acetone. These act as alternate energy carriers in the blood during periods of low food intake or in a specific situation of deranged biochemistry called ketoacidosis, which can lead to a severe lowering of the serum pH and several associated electrolyte imbalances. The most common trigger for ketoacidosis is poorly controlled diabetes, usually with an additional trigger such as an infection or heart attack. It can also be caused by alcoholism or starvation. Ketones can also be seen in the urine in patients on ketogenic diets, and by ketogenic diets, I'm talking about very strict and specific diets adhered to by kids with severe epilepsy, not necessarily the so-called ketogenic diets used for weight loss, which are much less extreme. Ketoacidosis is a pretty important diagnosis to make, so it would seem that the ability to detect ketones in the urine would be pretty important. Well, the problem is that the test used by dipsticks to detect ketone bodies only detects acetoacetate and acetone, while the predominant ketone body formed in ketoacidosis is beta-hydroxybutyrate. At peak severity, the ratio of beta-hydroxybutyrate to acetoacetate may be 10:1, greatly reducing sensitivity of the dipstick for clinically relevant ketoacidosis. This is why many labs no longer report it. An interesting phenomenon can be seen with treatment of ketoacidosis in that clearance of the undetected beta-hydroxybutyrate requires it to be first converted to the detectable acetoacetate. So as a patient is actually improving, the urine ketones can switch from negative to positive, giving the false impression the condition is worsening. The last tests on the dipstick are the closely related bilirubin and urobilinogen. To understand these, you need to understand the basics of bilirubin biochemistry and excretion. Within the reticuloendothelial system, the Heme molecule that sits in the center of hemoglobin in red blood cells gets broken down in a series of steps to a water-insoluble compound called unconjugated bilirubin. This travels in the bloodstream to the liver, where it's conjugated with glucuronic acid and excreted into the bile as the water-soluble conjugated bilirubin. In the gut, bacteria reduce bilirubin to something called urobilinogen. Some of the urobilinogen is further converted to stercobilin, which is a brown pigment and is largely responsible for the brown color of feces. In addition, some of the urobilinogen will be reabsorbed by the liver and it re-enters the bloodstream, where it will be converted into the yellow pigment urobilin. Urobilin is then excreted by the kidney along with some amount of unconverted urobilinogen. From this metabolic pathway, we can infer a few things about possible diagnoses from the bilirubin and urobilinogen present in the urine. For example, in hemolysis, in which the breakdown of heme is much increased, but the liver is working fine at conjugating and excreting it as bilirubin, the urine bilirubin will be negative, but the excessive excretion of conjugated bilirubin will necessarily lead to greater conversion to and reabsorption of urobilinogen. Thus, urobilinogen in the urine may be elevated above normal. In biliary obstruction, in which the liver is unable to excrete the bilirubin, it will begin to build up in the blood and some will spill into the urine. Occasionally, urobilinogen may be normal, or if the obstruction is severe enough that no bilirubin is making it into the GI tract, urobilinogen in the urine may be dramatically reduced. In other forms of liver disease, urine bilirubin and urobilinogen can be quite variable depending upon the circumstances. Unfortunately, time and experience has shown that the dipstick bilirubin and urobilinogen have fairly limited clinical utility, and a lot of hospitals don't bother reporting them at all. So that's all there is to say about the dipstick. The last part of this series will cover urine microscopy and provide a summary overview.